I am tasked with teaching you everything you need to know about hospital-acquired infections, and that would be a rather daunting task, except for the fact that you've had quite a few wonderful talks since this course has begun, and I'm going to quickly touch on those just so you know what to look back at for future reference. So I have no financial conflicts of interest. So this is just a quick list of what you have already heard if you've been here for the duration of this conference. As you can see, these are a list of some of the talks that revolve around hospital-acquired infections. And then there's also an additional talk that was given by Paul Sachs on antibiotics that's highly relevant, and I'd encourage you to look back at that. So, given the depth of topics already covered, I'm really just going to only focus on two key areas that I think are so relevant if you practice hospital-based medicine. One is multidrug-resistant organisms, and one is infection prevention and control. And these two topics have been in the news constantly recently. So first, let's focus on multidrug-resistant organisms. So this is really, multidrug-resistant organisms, or MDROs, as I'm going to refer to them, are really the largest growing concern in infection control in the last 100 years. And one of our largest, many people consider it our largest direct threat, and it comes specifically from the overuse of antibiotics. It's very straightforward. And when you think about MDROs, you need to consider these four important points. So one is the clinical consequences of having an MDRO. And it is not benign. So there are clear cases and strong evidence now that a patient with an MDRO is at increased morbidity and mortality, and that we've had over 1.7 million infections annually in the US and over 100,000 deaths that are specifically attributable to MDROs. Second are the economic consequences of MDROs. So we know that there's greater than a twofold increase in cost per MDRO. And we're talking about a $34 billion cost to healthcare. So anyone who's interested in the costs of healthcare and containing costs have to be thinking about MDROs. Third, and this one is so relevant for patients and their families, is the public image or the public perception of MDROs. And this comes up constantly in the media, particularly because MDROs are in the community now as well, and young people who were previously healthy are dying from these bacteria. And of course, the medico-legal liability that we all face in terms of infections. So I'm infectious disease trained. I love antibiotics. They have revolutionized medicine over the last 100 years in a way that really no other medication, in my opinion, has. But unfortunately, the downside of their usage is that they ultimately the bacteria that they're used to treat ultimately are able to mutate and develop resistance to the antibiotic for which it was approved. Over the last 100 years, we've had over 100 different antibiotics approved for use. But each new generation of antibiotic that's developed raises the bar for what's necessary to discover and develop. So we've gone, as you can see in this picture, from a time 50 years ago where there really were no MDROs to a period where a lot of infectious disease physicians are saying, we've reached the end of antibiotic usage. We are in a major decline. And we know, for example, in this period, that 1 in 2 patients in an ICU will have an MDRO. And this translates into twice the risk of death just by having an MDRO. So the IDSA, or the Infectious Disease Society of America, put out 2 landmark articles in 2009 in the journal Clinical Infectious Disease discussing these bugs. They're referred to as the escape bugs, and many of you have probably already heard about them. These bugs are extremely important because there are very few drugs in the pipeline that can treat these. And these are Enterococcus faecium, Staph aureus. They do a sneaky K-C thing here, so it's Klebsiella and C. diff. Acinetobacter, Pseudomonas, and Enterobacter. And you are going to see this again and again over the next 20, 30 years. So the scary thing is that we have to think about what is in the pipeline. And I know that as physicians on the front line, we're not always thinking about R&D, but we have to be, because hopefully we can, some of us, maybe all of us, can become advocates for more development of antibiotics for these types of organisms. So between 2000 and 2009, 9 years, only 3 new antibiotics were approved by the FDA to target MDROs: linezolid, daptomycin, and tigecycline. And anyone who practices hospitalist-based medicine certainly has used these many, many times. Unfortunately, only tigecycline is really effective against the MDR gram negatives. But it has some caveats to it. It's really only effective for treating complicated skin infections or complicated intra-abdominal infections. And we now know that tigecycline is linked with an increased mortality in patients with hospital-associated pneumonia, particularly ventilated-associated pneumonia. So tigecycline is having a more and more narrow usage range. So why are there so few antibiotics in the pipeline when this gets so much press and so much attention nationally? Well, it comes down, unfortunately, to a matter of dollars and cents. Most antibiotics are used for short course, and most antibiotics are not as expensive as other medications, so there's not a lot of economic incentive to develop antibiotics. And then secondly, the FDA, the way it approves antibiotics, they approve it based upon the disease state. So for example, pneumonia or UTI, as opposed to the organism that this antibiotic is targeting. So that can also impact and delay development. So I thought I would show you a real world scenario. So this is our lovely hospital. This is a screenshot from a patient who was hospitalized in 2010, so just a few years ago, who had a UTI. And I want you to take a look at the resistance pattern here. This is real. I didn't make that up. This was given to me by our infection control folks. So all of these common antibiotics that we would reach for are resistant. We in Boston are not immune to what is happening locally or globally in terms of MDROs. And we are now starting to see what we call extensive drug-resistant organisms, or XDR. And these are resistant to all antibiotics except for colistin. Now, those of you who have been practicing medicine for maybe 40+ years might remember colistin. It was something that was phased out in the 60s and 70s because much safer and more efficacious antibiotics were in use. So now we have to reach backwards to start pulling things out of the closet that hadn't been there before. So colistin,